this Q&A discussion. So again, thank you. I am LaRon Nelson. I am a faculty member in the School of Nursing, associate professor there and associate dean of global affairs and planetary health, and also secondary appointed faculty in the Yale School of Public Health in the Division of Social and Behavioral Sciences. So I'll start by saying a bit about the Ready Hub. So this is, the Ready Hub has brought this series to you today. Leveraging the expertise of Yale's Centers for Methods in Implementation and Prevention Science and the Center for Interdisciplinary Research on AIDS, READY, which stands for the Rigorous, Rapid, and Relevant Evidence, Adaptation, and Implementation to Ending the HIV Epidemic Implementation Science Hub, provides technical assistance to 10 ending the HIV epidemic projects in New York, New Jersey, Alabama, California, Florida, Pennsylvania, Georgia, Illinois, and Texas. READY does this in collaboration with the Implementation Science Coordination, Consultation, and Collaboration Initiative, or ISCI for short. With ISCI, it creates opportunities to translate local knowledge into generalizable knowledge whenever possible. READY offers comprehensive expertise in implementation science methods, frameworks, strategies, measures, and outcomes in HIV/AIDS research, design and management of experimental and observational implementation science studies, data collection and sampling, quantitative, qualitative, and mixed methods analytic approaches, partnership formation, community-based participatory research, and public health ethics. Today's event is co-sponsored by the Yale Center for Methods in Implementation and Prevention Science, or CMIPS, sponsored also by CIRA and by ISCI. If you would like to know more about future Ready webinar events, please notify Christine Simon in the chat and she'll make sure you're added to the email list. So, very excited today to be moderating this conversation with a dear friend and esteemed colleague, Dr. Marcella Nunez-Smith. Dr. Nunez-Smith is the C.N.H. Long Professor of Internal Medicine, Public Health and Management, the inaugural Associate Dean for Health Equity Research, founding director of the Equity Research and Innovation Center, or ERIC, director of the Center for Research Engagement, Associate Cancer Center Director for Community Outreach and Engagement at Yale Cancer Center, Chief Health Equity Officer at Smilow Cancer Hospital, Deputy Director for Health Equity Research and Workforce Development at the Yale Center for Clinical Investigation, core faculty in the National Clinician Scholars Program, research faculty in the Global Health Leadership Initiative, Director of the Pozen Commonwealth Fund Fellowship in Health Equity Leadership, and co-director of the Doris Duke Clinical Research Fellowship. Dr. Nunez-Smith's research focuses on promoting health and healthcare equity for structurally marginalized populations, with an emphasis on centering community engagement, supporting healthcare workforce diversity and development, developing patient-reported measurements of healthcare quality, and identifying regional strategies to reduce the global burden of non-communicable diseases. She has extensive expertise in examining the effects of social and structural determinants of health, systemic influences contributing to health disparities, health equity improvement, and community academic partnered scholarship. Most recently, as the COVID-19 pandemic has shed national attention on the health and healthcare disparities of marginalized populations, she was called upon to serve on the governor's Reopen Connecticut Advisory Group and to chair its community committee. She served as an advisor to the Biden-Harris campaign and subsequently named co-chair of the Biden-Harris Transition COVID-19 Advisory Board, where she serves as chair of the COVID-19 Health Equity Task Force in the administration. The topic of this Q&A session with Dr. Nunez-Smith is health equity and implementation science. We will open up the floor for questions. Feel free to enter your questions into the chat. So thank you and welcome, Dr. Nunez-Smith.
Good afternoon, everyone. I'm so excited to be here. Thank you. My apologies for making you read all of that. My goodness, LaRon. I'm Marcella from next door.
It is quite an extraordinary.
Open the door for me. There's someone to get in. I'm coming down.
There is.
Oh, the door for the house.
let's get some folks muted here. Anyway, it's quite an extraordinary accomplishment to sort of read through your contributions. And I think it's important to sort of start there. So as humble as you are, it deserves to be said. And it was an honor to say it. So thank you again.
It's an honor to be here. Appreciate it.
Thank you. Well, let me start off with the first question. Given your experiences developing and implementing community health programs to serve the needs of communities that really have faced long histories of structural barriers and oppression, what have you found to be, what would you say is the most important for integrating health equity into your work?
Wow. I appreciate that question. And it's not a small one. You know, I look around the Zoom room, as it were, and in some ways, I wish we could be really interactive, because I think a lot of people here have a lot of lessons learned. I'm always very hesitant to say expertise in this area, because you just have to, stay in a spirit of constant learning. And I'll use your word, LaRon, humility, because so often the work of the Health Equity March and the Implementation Science March are, you know, it's going to be about course correction and pivots and being able to recognize, right, when the way you're doing it is not the right way. Maybe the way that you've always been doing it is not the right way. So I think I'm still in a process of learning a lot of lessons in that regard. I mean, probably as far as maybe anchoring principles or thoughts or values. And this most certainly was reinforced. I mean, something that I get to do every day here with so many of you as colleagues on our work, you know, at Yale, our work in New Haven, across the state, across the world. These were lessons I certainly took with me into the work with the administration, during the transition, and of course, during my time with the various you know, entities at HHS and the White House, as we were thinking about a COVID-19 response for a nation that would be equitable, or as equitable as possible. And perhaps what I can say in response to that question is some of what I would go back to as my North Star principles. And you know, whenever it comes to equity and integrating equity in our work, or whatever our work may be, it is to remember it's hyper local, right? I probably have three things I would say. One is it's always hyper local. Any work with health equity is going to be or should be hyper local, and so certainly from the federal role and administration, that was important, right? What are the supports that are needed at the very local level? To recognize what the role is of those of us working in that setting, which really is to be in support and in service of those on the ground, in community, with community, those who are most affected. I mean, the only appropriate time to use expertise in this context is the communities that are most affected. That's where the expertise is, that's where the wisdom is. And that's going to vary, could even vary block by block. And so recognizing just the extreme hyper locality of this work, there just isn't another way to do it and have it be successful. Maybe my second principle, I would say is, and the caveat here is at least for me, these remain also always aspirational. I don't want to kind of make a list that seems like this is so straightforward and the path is clear, right? But, you know, I would say my second is making sure, particularly when we get into this space of intervention, I'll just use that term really broadly, it needs to be community-led, right? And for many of us who are researchers, I think we could attest to the fact that, you know, not just community engagement, which is important and has value in place, but when we are dealing with some of the most difficult challenges, and I will put COVID-19 squarely there, making sure that we look to community for solutions and make sure that when we do that, it is beyond, dare I say, you know, a listening session. And I was honored to lead many of those, but I always said in every listening session through the White House that my job was not to listen, it was to do afterwards, right? And it was to make sure that the resources were there to operationalize the solutions that came from the communities that hold that situational wisdom. And so being hyper-local, being sure that we are community-led and all that that entails, because it is about often ceding power in terms of decision-making. It's about making oneself accessible always, and it's about the provision of resources, if that is the role you can play. The third, I would say, is sustainability, right? So how do we make sure that the work that we've done that is hyper-local, that is community-led, has a finite conclusion that is well understood and appreciated by others, that there is a deliverable, a goal that we know when we get there, that work has been completed and on to the next, or that this intervention, this work we are doing right now can be sustained, will be sustained. And I feel like that is our obligation. So I think those are the three that I probably visit most often across the various projects I get to work on in the research teams or in the roles I'm fortunate enough to serve in policy and other spaces.
Yeah, that is fantastic. These three principles, the hyperlocality, it being community-led, and sustainability, because these systems, right, or these structures that marginalize people are not cross-sectional. They're not going to go away, right? And they're really good. These systems are really good at finding ways to reproduce the oppressions that some folks sort of come in and try to address at one time point. But unless we dismantle them, they're always going to be there. So they require community-led efforts to keep finding ways to make sure we're not back into these sort of status quo situations, and that work can continue into the long term to make sure that that we're not back, right? They don't get sort of comfortable, and then communities sort of fall back into these situations where they're still trying to fight these systems that marginalize and oppress them and overexpose them to infectious diseases like COVID, but also to non-communicable diseases. Absolutely.
I really appreciate you saying that, LaRon, and my apologies. And I know, and I don't see the chat, so certainly to wait, but I just wanted to express appreciation for you saying that, because I think for so many of us, when we talk about health equity, we talk about implementation, science, and all this work, that's what keeps me up at night. I don't know about anybody else, but that is, loss of brown maid, right, is what keeps me up. And I think we just have to always be speaking that truth, right, LaRon, that so often, I cannot at this moment think of an exception to this rule, that when we are doing this work, we are doing it in the setting, in the face of what has not been accidental, but what has been structurally and systematically put in place to marginalize some, right? And to perpetuate inequities. And we don't often speak that difficult truth of where there has been benefit derived from the fact that inequity exists. And so all of that is part of that conversation. And so maybe that's the fourth principle that you just put out there, LaRon, is the truth-telling one. So I'm grateful for that.
Gotta tell the truth. Tell us an example. You've seen so much and you've led so much. Tell us an example of where you've seen health equity integrated into implementation science done particularly well. Does there one that come to mind?
Mm-hmm. Oh my goodness. Once again, I am surrounded by so many people whose own work exemplifies this. And even just to take a moment now and reflect, to be here in this conversation, to look at this community that we have here is really special. I mean, I would say that these aren't necessarily frameworks or ways of thinking, or really ways of being and ways of leading that would have been the default right across our university and school. Even short years ago, which we have had many champions for as long as I've been around here, and longer for sure. But to see kind of this coalescing of community in this way is really, I think, quite spectacular. And I hope a question like that can really generate for us maybe our own capture of all the great work that happens right here that I think really would illustrate that question. As I said before, I think that whether it's having the opportunity to think about work here and the research partnerships here, or even looking back to something like that national lift to let's say connect everyone with vaccination. Maybe I will think of an example from there. In the White House, our team launched something called Shots at the Shops, right? Which is an initiative that partners with many academic institutions, expertise leaned on here at Yale, Stephen Thomas University of Maryland, and others, but also a partnership with industry. And we partnered with a company that has a whole line of what are Black beauty products to really support Black-owned beauty shops and barber salons, to be sources of trusted and trustworthy information about vaccines, COVID-19 vaccines and vaccination, and also to be venues for vaccination opportunities. And I think kind of everyone brought to that a lot of the lessons that were learned, right, about meeting people where they are. And I say that's not just something figurative that we say. Certainly we want to make sure we are meeting people where they are in terms of the information that people need to receive and who they need to hear it from. But in a very literal way, where are trusted spaces as well as the trusted messengers that we often talk about. And so I think when there is that kind of attention and intentionality, in this case, it's a campaign, when there is that multi-sectoral partnership, right? So recognizing that these are business owners that we are working with who have earned trust in their communities over time, but they are there as business owners. And I think being able to have that lens as well, we often want and expect, and this I would say maybe is academia, maybe is government, but we expect so many people to show up when we kind of ring a bell and we say something is so urgent and in crisis. And we don't stop to think of what that entity's primary work is or primary mission. We somehow think that the time should be there for whatever our priorities are. And so this was able to really compensate, right? This campaign, this initiative to compensate those shop owners. And this is what a private-public partnership can do for the time, right? The opportunity cost, as it were, that they were taking to be able to be in this partnership. So, I think there are some elements that are there, but I do begin always with saying, we have to compensate people for the expertise, for the wisdom, for the time. And there are a few other spaces where I ever see an expectation that people will bring their knowledge, their skill set to bear, and we don't have adequate conversations about compensation. So, you'll get me back on track, LaRon, but I think that there are these kind of bigger ideas around being sure that we are walking with that intentionality. We are doing that truth telling about things like resource sharing and compensation. And usually that's a good start, right? Necessary, maybe insufficient to get us all the way, but without those, we're not going anywhere.
Your example hit on all your 4 points. Hyperlocality of it, that is community-led, that is sustainable. It's actually being done by people who are anchored in the community. And the truth, like coming from people that have earned trust, right? You can't command trust in a crisis. They expect people to trust you. They might do what you say, it doesn't mean they trust you. And so that's an excellent way to even see how you tie it in all 4 of those and recognizing something that worked really well. Now, we know, right? We've known for a long time what some of these structural issues were. And there are many people, some notable examples, who are leading this in their research, but also in communities across the country. But it's not at scale, right? Everybody's not doing it and not doing it enough. What do you think that's about? We have this evidence about the need to address these structural issues, and advance health equity to get the types of outcomes we want for health for people, but it's not happening. What do you think are the barriers to really sort of broad scale integration of health equity into research?
Yeah, that's a great question. How much time do we have? So, I think, where are those opportunities, right? That's the right question. Like, where are those opportunities? Where are those levers? How can we do differently and do better? And I will say that I derive a lot of hope. I completely agree with you, or, the sort of this assessment that we have pockets of excellence, maybe I dare say, where they're, and to be really clear, not new. This is something that I've said so often in the past year and a half, right? I mean, that for some people, perhaps these are new conversations, but for a lot of people, these aren't new conversations. These aren't new understandings, right? We've kind of, even in my training, was fully aware of what these structural realities were and the interplay with health, but this is a long list, right? There is not a sector where we couldn't have this same parallel conversation. So, but I've been privileged to also have a chance to think about, like, where is there opportunity for this to be normed in a way, talk about scaling and scaling up from these various nodes of just outstanding collaborative scholarship that have been generative, impactful, longstanding, and adapted elsewhere. I will maybe just one. I think there are many opportunities, and I do continue to think that, I've had many periods of worry about kind of how long there would be attention on questions of health equity broadly. But I do think there are opportunities now, and perhaps there are just doors that are ajar and can be pushed more open now than maybe in the past. But let's just take one example that might be relevant to a lot of people here, right? I think I see in some of the way that we think about and fund research as a way to really at least have one stool of this conversation, right? So when we think about what we are looking for, let's say a funder such as the NIH, how do we think about that process for what we call for to be funded, the review process and how that works, how we think about what progress and success looks like and how we measure that in the research space. And I'm sure many of you have been, but I've been in some really exciting conversations in this past little bit, about, where those opportunities exist in institutions like the NIH to help really steer people and where a lot of people really want to go, I think, but help kind of align these incentives to make sure that we are doing the work the way we know we need to for the ROI that we should be demanding, which I think is equitable outcomes.
I love that. We're going to run out of time.
I told you, I was like, how much time do we have?
Yeah, this is great. So we'll see if some questions come in through the chat. I'm monitoring that, and I believe Christine is too. One of the things that you made me think about is, you said it earlier about the need, what it requires to advance health equity, what it requires for a community to be in the lead. And some of that is ceding power, I think is what you said. And that might be tough for people to recognize the opportunity in the context where it means they have to give something up. But part of how I liked you framing this as an opportunity is that it might mean giving up something, but it doesn't mean you lose, right? And that you can give up something so that more people win, and that you also win, and maybe win in a way that is more sustainable and more meaningful. But I think being honest about what it might really mean for people who hold sort of concentrated power, about the need to give that up, but not in a sense where you lose. And I think there can be this sense of sort of loss of prestige, of power, of opportunity. And I think what you offered us is that that's not necessarily the case.
And I'm sure, LaRon, only to say, I think, with books like Heather's, like Heather McGee's, the Some of Us, and I'm sure others have read, but I think this idea, so often, you're right, we have to finish that thought, right? There are costs to all of us to continue in this inequitable system. And so even those who are quote unquote most advantaged, most privileged, who are holding that concentrated power, there are costs. And so that is part of this conversation too. And I think that is just perfect. I will borrow that from you if you allow me, right? Which is that you can give up without losing. And you can actually give up and win. And when we take that future watch, particularly if we are looking to that next generation, to those 7 generations, right? If we are looking to the future, that is the only conversation you can have. And that is, you know, such an important lesson that you get in something like a global infectious disease pandemic, right? We are not okay, not any one of us, until and unless we are all okay. That is the basic rule. And so I think that's just so critical, and I love the way that you summed that up.
Thank you, thank you. We're going to get one question in under the timer. We have Donna Spiegelman's hand is raised. Donna, if you can hear us, you can proceed with your question.
Yeah, great, thank you. Thank you, LaRon, for moderating, and thank you so much, Marcella, for being here with us today. My question, Marcella, was thinking a little bit more globally. There's a lot of talk about health equity, and in particular in relation to implementation science in the United States. And some of us, yourself included in the Eastern Caribbean, are doing implementation science work outside the United States, where actually, you know, as a sort of naive observer, there are also maybe differences by class and ethnicity and religion and religious minorities and so forth, yet many countries aren't talking about these kinds of things in the same way we are right now. And I'm wondering what you think, how the concept of health equity and implementation science translates to global health and global implementation science work, especially when, say, we're coming in as maybe the funders or the high-income country partners and so forth, and there's already these big power differentials.
Yeah. No, I mean, I think that's a great, you have an entire session on that, right? So thank you, Donna, for that question. Because I maybe that I would love to be also a learner there. I think there, you know, again, in this opportunity theme, there are some conversations I certainly have with colleagues that, you know, their argument is that certainly they are already and are being guided by implementation science and health equity, and, you know, language may be different, but certainly there. And I think there is an increased understanding, particularly that US funder side, that we need to learn more and kind of be in that posture of learning and humility and understanding from our global colleagues. And I'll just leave people with one example, right? When we think about community health workers and the role there, the important role, and talk about something that is hyper-local and community-led and sustainable, right? And provides economic opportunity for people. And we can learn a lot from how other countries that we refer to as limited resource have really been able to leverage with great success those kinds of workforce intervention. So one example, but there's a long list, but I agree there's going to be a lot more about how those collaborations should look. What does power sharing look like in those arrangements? And I think you just have the topic for another seminar right there.
Mm-hmm.
Thank you for that. Dr. Nunez-Smith, it's always a pleasure. Thank you for spending this half hour with us, answering these questions. Want to give great thanks to CMIPS, to CIRA, to the Ready Hub, and to ISKI. I put a link to CMIPS in the chat, so feel free to check them out and be in touch if you want to hear about new upcoming webinars that you can participate in. Dr. Nunez-Smith, thank you for your leadership. Thank you for your stewardship and for your service to the country and to the world. We appreciate you.
Thank you. Appreciate you. Be well, everybody.